So good afternoon, everybody, and thank you very much, AFPA, for inviting us. May I start, sir?
Yeah, you may.
Yeah. So today's
Please silence, please.
So-
All friends, please keep silence.
today's topic is new era in structural heart disease. We are seeing day in and day out all mitral valve replacement, aortic valve replacement. All patients usually require surgery. There are certain areas where intervention has now taken over, and I will be presenting few cases which are done at our institute at Epic.
Please keep silence.
At
Please.
Epic, there's a heart team approach. So we work collectively along with surgeons and interventional cardiologists all work together. And we decide which mode or which approach is best and better for the patient outcome. So here are the few cases which are very complicated cases which were done at our institute. So first case is of degenerative tissue mitral valve. This patient underwent a mitral valve replacement years back and then again had a problem. So this was a case first done at our hospital where we inserted a percutaneous mitral valve inside a old degenerated tissue valve. Going to the patient profile, she was she's a 61-year-old female with a history of mitral valve replacement, obese lady with obstructive sleep apnea, and previous pacemaker implantation was done. On 2D echocardiography, she had a severe degeneration of mitral valve leading to MSMR. And as a heart team, we decided that she's a very high risk for surgery. So transmitral approach was decided. So before going for the procedure, we have to do certain analysis which are very tedious, and this is the crux of the entire treatment where preoperative analysis is most important aspect. We analyze the entire mitral valve in various transesophageal echo as well as CT, and we define various diameters of left ventricular outflow tract to mitral angles and everything. So CT is a gold standard investigation of choice or diagnostic before going for this intervention. So we decide where to puncture the interatrial septum, where to enter the mitral valve and everything. So the procedure is we go from the groins of left and right femoral axes are taken, and thereafter the procedure is done. So under the TE guidance, we perform the septal puncture first, and after septal puncture, the guide has been navigated, the guide wire is placed. Once guide wire is placed, the pictal is inserted across the valve into the left ventricle, and thereafter the valve, degenerated valve, is dilated with a balloon. Once this is done, the new valve is inserted across the valve. Its place is exactly matched under the guidance of T, and then it is inflated. So this is how it opens up. Everything is done under TE guidance. So once it is placed, things are taken out, and this it's a new mitral valve in place. So this procedure usually takes an hour or so, but patient is extubated immediately and can be shifted to ICU next day in ward. So this is the fastest recovery route, and patient hemodynamically became stable, and within few days she went home. So this was about all mitral valve. So take home message is, when there is a hemodynamic severe degenerated valve and it cannot be operated surgically, there is a new hope where you can change the valve with percutaneous approach. Provided that valve has to be a tissue valve, mitral valve cannot be approached, metallic valve cannot be done with this route. So now let us move to another valve, which is an aortic valve. We had done few aortic valve replacement cases at our hospital. I will share few of them. So these are typical patient profile. 78-year-old lady, diabetic hypertensive with LV dysfunction. On echo, she had severely calcific aortic valve, severe AS, moderate AR, mild TR, and mild MR. History of CBA 3 years back. She was a high risk for surgery. So ECG was suggestive of interventricular conduction defect with left axis deviation. Angiographically, she had very minimal coronary plaques. Creatine was 2.9. CBCs and LFTs were normal. STS risk score was 12.2 and Euro score was 44 point, which puts her into a very high surgical risk. So looking at the aortic valve, it degenerates as the age progresses. Right from the normal valve, the calcification starts, orifice starts narrowing, and it becomes pinpoint. So if you look into the natural history of aortic stenosis, it increases with age. And a person, when it crosses 80 in the 8th decade, it's around 9.8%. It's nearly as good as 10%. So with each decade, risk of aortic stenosis doubles. And as increases, the disease accelerates. So the progression is very fast as the age advances. Now, the best time to intervene in aortic stenosis is when the symptom starts. So usually in cardiology we call it as ASD. It's not atrial septal defect, but we call it as angina, syncope, and dyspnea. So when ASD occurs, any of the three symptoms occurs, it's time to intervene, because after that the progression is very fast, and survival after the onset of symptom is 50% of 2 years and 20% at 5 years. So it's very much high. So surgical intervention is needed when any of the symptoms occurs in a patient with aortic stenosis. Now in old age, in octogenarians, the surgical mortality is pretty high, and there was a need to find some solutions. So what happened? Scientists started searching for some options. So in 1993, there was a first description of valve sutured on a stent, and it was animal model. However, they didn't succeed because coronaries got blocked. However, they got succeeded, and first human implantation occurred in April 16, 2002 by Alan Crevier. And this was the first case where aortic valve was implanted percutaneously. So before going for any aortic valve replacement percutaneously, there has to be certain investigation like CT, and we have to take specific measurement, because if you don't take accurate measurements, you can land up in trouble post procedure. So best is annulus size we have to accurately measure, and because the annulus is the most important parameter in aortic valve percutaneous replacement, where it's actually not a straight away, it's like a crown. So proper measurement are taken, and the best way to take this measurement is a CT angio. And based on the CT angio, all findings are done, all angles are marked, all size of the valve is decided upfront. It's not that we go in and find something else. Everything has been decided pre-operatively before the procedure, and things are ready. So CT is a most important tool, and it's been studied thoroughly before doing this procedure. So this was a case, 70-year-old lady, where you can see it's a severely calcific and severely stenosed valve. The valve is crossed, pre-dilated with a balloon, and there's a temporary insertion. Temporary pacemaker is already been put. So while inflating the balloon or valve at aortic level, you have to go up the heart rate around 200, 220, where you can easily inflate the valve without any movement. So this valve was inserted. No rigors, no paravalvular leak, and final gradient taken across the mitral valve. So it was excellent result. Another case, same elderly male with post bypass status, class 3 shortness of breath, recurrent admission for the same. Echo showed LV dysfunction 35% with severe AS and severe PH. Again, same heart team approach was taken. Surgeons and cardiologists took a decision to go for this valve. So balloon is inflated. You can see the rapid atrial pacing. You can see how fast the pacing is being done. And that time the heart is standstill while you are inflating the balloon. So this is how it's done. Once balloon is done, immediately heart rate is brought down back to normal. Once it is done, balloon is done, valve is opened up, then stent comes. After exact localization of the stent is expanded. You can see under the rapid atrial pacing. So, and this is the final result. Sometimes while stretching aortic annulus, patient get heart block. In one patient we had that, and post-operative he underwent dual chamber pacemaker. So it's around, incidence is around 6% with balloon mounted valve, and it is in 2-digit with self-expandable balloons. So if you go for which are the ideal cases for percutaneous valve replacement, so these are the old age patient, more than 70 year age, past history of surgery or post valve replacement, patient with previous chest radiation, and with a lot of comorbidities like hepatic or renal dysfunction, previous stroke, severe LV dysfunction, COPD or fibrosis. In short, those who are high risk for surgery, they can be subjected for this procedure provided they have suitable anatomy. So surgical choice for aortic stenosis is surgical valve replacement. We do routinely at our institute. TAVI, that is the percutaneous replacement, balloon angioplasty. So if you want to avoid surgery, you have an option now. Now there's one more important etiology where in atrial fibrillation there is a recurrent stroke. So all patients on atrial fibrillation are on some oral anticoagulants or NOACs. So 15% of the all stroke and 30% of strokes in 80 years of age do have occur because of atrial fibrillation. Strokes due to atrial fibrillation produce greater disability and worse outcomes. So we all know no one likes stroke because of atrial fibrillation, and it's all because of the clot occurring in the left atrial appendage. 90% of the clot occurring in left atria because of atrial fibrillation is in left atrial appendage. It's non-valvular atrial fibrillation, and we start patient on oral anticoagulants or NOAC based on the Chadwick score and Hasbled score. So depending on the score and severity of the score, patient is subjected for blood thinners. Now, but certain clinical scenarios do occur where you cannot prescribe such NOACs like vitamin K antagonist. So as an example, she's a 74-year-old female diabetic hypertensive. She had a ICH, hypertensive ICH 3 years back, and now presented
Sir, 2
with,
minutes remaining.
yeah, presented with sudden hemiparesis. So now you cannot prescribe anticoagulants in such patient. So need of treatment, even if you prescribe, it will occur. So there our team decided that what can be done further. So there was approach known as left atrial appendage closure, and based on this, I will skip. So based on this, appendage closure was planned, and there's a special device is available where you go there and plug the left atrial appendage. It's a percutaneous approach and it's done under TRE guidance. Prior to that, CT is also done to decide the anatomy and type of the LA appendage. So 90% of the, as I told you, 90% of the thrombi present in non-valvular AF in left atrial appendage, only 10%, 60% in valvular AF. So these are the various devices available for closure of left atrial appendage. Why different shapes is because LA appendage do have different shapes. There are 4 types already explained, different types of appendages, and based on the size and shape, device is chosen. So these under the imaging of T, it is done. CT has been done prior, and this is how the procedure is done. Device has been taken under the guidance of T and it is placed. So in summary, you can do where NOACs are contraindicated. Left atrial appendage closure can be done. Thank you very much for patiently listening.
Thank you very much. Now, Dr. Venu Patel will deliver a trophy to Dr. Joyal. Dr. Joyal.